Thank you very much, Joan. Uh, so we're going to hold questions until we get John's presentation. John Landsverk is a senior scientist at the Oregon Social Learning Center, and he's going to be talking on a slightly different set of interventions in here that look at a focus around parenting as opposed to individual child kind of interventions. There's overlaps between all of these interventions, but that's where the primary piece of this model is. So, John.
Let's see. Okay. So I probably should have titled this, "What are you going to do with the parents?" I heard lots about kids because I think Joan does lots of work with adolescents. But with children's health, whether it's children or adolescents, you're always dealing with the parents. And I deal mostly in my research with very high-risk youth, which means that there are lots of problematic issues with competencies in parenting. So the parenting practices in primary care, this is a structured review. I'm not yet calling it a systematic review. We're not looking at meta-analysis yet at this point. Actually looking at some issues that relate to how do you implement and what do we know from those randomized trials that either forecast good implementation or not so good. So the overview is this is going to be a structured review, and the involvement of parents is critical for children's health, possibly even more so, I think, for behavioral health. And I'll talk a little bit about why primary care, what's the rationale for using a structured review, preliminary, and I will illustrate some of the findings with particular studies, and then what are the implications for a research and services agenda, because I think that's part of it, and also what's the implications for looking at the second group or third group this morning with David Hawkins on advancing evidence-based parenting programs in primary care settings. This is a slide that suggests that we know lots about changing parenting behavior. We have 35 years of history. Patty Chamberlain was good enough to give me this slide to show, and it really summarizes that we know lots about how to change parenting and what are the things in changes in parenting that will result in much better outcomes for their children. So it's highly related, I think, to this topic. So you can get better, certainly mental health and substance abuse outcomes, and I believe also physical health outcomes with engagement of parents and potentially some changes in their competencies. This just shows in the red what are the positive things that we know from 35 years of research, and also what are the things that we know in the opposite direction, less involvement in juvenile justice. Most of you will know a fair amount of this literature. What's incredibly important here is that we have so many trials and so much that we know about changing parents and also in parenting models, that's a good base to start from. And I wanted to start from that here. We also know what the targets are, what the mediators are. 4 things, again, it's a slide that Patty developed because she certainly knows this area far better than I. You've got to increase positive and sensitive parenting. You've got to decrease harsh parenting. That comes out in most studies. You've got to decrease parenting stress. So you've got to deal somehow with parents and their own behavioral health issues, and you have to increase the attachment. So those are the targets. Why a structured review approach? It was a really nice quote from Glasgow, Vincent, Chambers, a bunch of NIH folks that talked about what do we know about implementation research. The translation cycle is guided by ongoing and updated knowledge synthesis with structured reviews of the status of science to guide implementation and large-scale dissemination research. Certainly hearing Joan's talk, one now feels much more confidence that it's time to figure out how do we pay for and how do we implement successfully integrated models. This is an old slide that has been very useful. It comes from Hendrix's work on the IOM report on prevention. And it just shows that the notion of stages of research. And within the stage of implementation research, phases of it should be considered as we think about it. And most of the work that we're talking about this morning is really about what are efficacy trials and what are effectiveness studies. And the next stage is really, you can have all of that, but how do you implement successfully will make the difference for a population impact. The questions for this review is, what studies met the criteria for inclusion and exclusion? Most important, how were the studies carried out? Was the design in the studies where the parenting practices were included along potentially with screening protocols within primary care settings, full partnership there? An integrated model, I think, is what one would think of that. Or were they outside? So there was referral from primary care does. So those are two classes of studies that we see here, what challenges were, and then what technology was used. Because we're really moving into a period when fast-changing modes of technology may truly impact both the effectiveness, the implementability, and particularly the cost. Did a bunch of searches. I will not, I took some of those out. Here's the Prisma one. Essentially, we start with 1,985 studies, or they're really papers. There's some multiple studies in there. End up with full text review only on 74 that had anything to do with primary care. And of those, only 35 in our view at the present time belong in this review. So it really slims down enormously despite 35 years of history of randomized controlled trials in the area of parenting programs, parenting practices. We looked at it from 1995 to 2014. We did include other countries, including we have a paper in there from Japan, Norway, UK, Netherlands, et cetera. Lots of different foci in these studies in terms of the parenting practices, but that's the mediating force in there, and child and family outcome targets. Now, here are the preliminary findings that we have, because we have not yet gone into looking at the government randomized trials, because that's a pipeline that we want to see what's the character of those studies that are being funded and that we'll be seeing in the future. Basically, there are two classes of studies, full mounting behavior, a full integration mounting behavioral health screening and services on PC platform, that is to say mounting parenting interventions on primary care thing. And two, referral for behavioral health from primary care settings. There have been classification challenges that Hendricks is working. This really is being supported by Hendricks' NIDA-funded center, structured review, and Grayson Cruden is doing all of the background work and the systematic review. What do you do with community maternal and child workers? Because there are some studies out there that show them. Now, are they considered to be part of primary care, or they're really more of the public, the MCH part of it? So that's one thing. There's some nice studies. They're using parenting practices. They're involved in research on it. Two is we use clinic, which is a problematic search term. It brought in, so we really had to take out a bunch of specialty clinics in there. They have nothing to do with the kinds of primary care settings we're thinking about. We had studies that show up from the NICU. Primary care in the title of the article is actually a pretty good predictor of whether this is going to really be about parenting practices and primary care. That the authors have been very clear about putting that in the title and making that known. Classes, subclasses, and illustrations. Now, I don't think we've done the coding precise enough yet to report on what's the various characteristics, but we certainly know something about this. And so I've chosen to actually give you a flavor of the kinds of studies within classes. So what about where you have screening and then behavioral health, mounted on a primary care platform. So Berkovitz in 2010 published a study, and the titles are quite indicative. Early identification and intervention for behavioral problems in primary care. A comparison of two abbreviated versions of parent-child interaction therapy. Now, this is at the other end of the spectrum than probably a number of this, that YPEC, that sort of thing, in the sense of very young children, 3 to 6. Of course, that's where PCIT does its work. There was randomization at the individual level. The treatment was done in the primary care settings, and the treatment was done by non-primary care personnel. So they were not fully integrated in that way. There were no differences observed between the two versions, but both showed decreases from pre-treatment. So the good news is you've abbreviated a very well-researched, evidence-based intervention for young children with many of them with very severe behavioral problems. You've done it in abbreviated fashion, and you're still getting decent outcomes, and you actually now have an alternative between two models. That's not a bad place to be in when you think about implementing. A second study illustrates a class of screening in the primary care settings and doing the behavioral health work in community settings. Kjobi and Ogden, 2012, this is a Norwegian study, but Marion Fork Ash and Parent Management Training has gone to Norway in a fairly big way. And they called it a randomized effectiveness trial of brief parent training in primary care settings. Again, notice abbreviated in the first study, brief in the second. There's something that's going on there as we move here. Age 3 to 12, broader range. There was, again, randomization at individual level. There's not yet cluster randomized designs. Treatment is provided outside of primary care settings. I think it's because essentially PMTO was brought in by Specialty Mental Health in Norway. And again, even though it's a brief version of PMTO, it showed significant intervention effects. So both of these illustrate something that's happening, which is if you're going to put a parenting intervention into a primary care setting, you better think about number of sessions and how much burden there's going to be and how quickly can you move that out. Of course, it always brings in the question of for which kids. Can that also work with very severe kids as opposed to, say, more moderate? Both of these used cut points in terms of screening, and so that it was not universal. This is a study, again, of screening and behavioral health on primary care settings. Ellen Perrin is the lead author on this one. I chose it to illustrate it because Ellen is a very good working pediatrician. And this comes then from a part of the academic world or the practice world that's not psychiatry or mental health, but it's pediatrics. Age 2 to 4, again, a very, very young population. Notice again is that improving parenting skills for families. Here, they use multiple sites, 6 private practice agencies, and also 1 federally qualified health center in Boston. So now you're beginning to see studies that are being done in multiple sites, which from an implementation point of view is very important because then you can look at variation in performance and implementation. There was randomization at the individual level. They used weightless controls. They used, here again, an abbreviated version of Carolyn Webster Stratton's, well-known incredible years. Generally, Carolyn starts it at 12 sessions, and this way brought it down to 10. And it was a cluster, I'm sorry, this one, it was not a cluster randomized design. The parent training group was generally carried out in the primary care settings. So the parents were coming to that primary care settings, and they were group co-led by a research clinician and a primary care staff member. Again, more of an integration and being done on a primary care platform. And there were, again, the good news of significant intervention effects despite a modification or adaptation of a well-known and well-researched parenting program. The fourth study is Larry Wissow, a study out of Johns Hopkins published in 2008. And this is slightly different from others. This is screening at primary care settings, behavioral health at primary care settings, and primary care providers delivering the behavioral health. So this was ages 5 to 16, randomization at the individual level within 13 sites, New York, Maryland, and DC. They use cluster randomization. I don't understand, actually. So I just have, that's my question mark, because they randomized within a cluster. And the treatment was provided by primary care providers. They found effects, interestingly, for minority children that were involved in the experimental condition, but not for white children. And they did find effects for parents on both sides. Here again, you see a question that comes in around these kinds of studies is, do you also try to not only change the parenting practices of the parents, but do you try to attend to stress levels, but particularly behavioral health issues for the parents? And Larry Wissow's did in this particular. So it's a different kind of variation on this theme. There's one final one that I wanted to use as an illustration, some work that's been done by David Kolko, who's really moved into the area of implementation and how do you move these into primary care. He used a very clear cluster randomization with 7 community pediatric and 1 academic. Of course, this is Pittsburgh. They used screens and treatment provided by hired social workers that they brought into the primary care setting. The outcomes suggest this model is feasible and broadly affected. So I suspect that this may or may not have been one of the studies that you looked at as well. Now, so what can we say at this point? First of all, we see major, even brand-named parenting programs that have been well-researched, multiple RCTs. I mean, I think IOI has got something like 8 to 10 RCTs that they've been doing, all of them quite successful. But you see the adaptation to the setting, which is an attempt to essentially make it more efficient, to bring it to a more abbreviated form with some promising results. That's good news. There were very few examples of full primary care setting models, the more integrated models, in the studies that we have been reviewing, where they have both screens and behavioral health treatment and the involvement of primary care personnel. I haven't found a smidgen of evidence in any of these studies of the word cost does not appear. That's all, simple as that, in the RCTs. And there is little focus on any kind of things about implementation. It just isn't there. They're classic kind of, does this work here? And they will talk about, we showed that this was feasible, but there's really no measures of feasibility or whether you could migrate these to a larger number of kind of primary care settings. There was some use of multi-site studies, and of course, that multi-site studies for both quality improvement and implementation research are very important, because then you can look at variation in performance, and you can think about how to use the quality monitoring to bring those low performance up to a higher scale. Using some cluster randomized designs, which have become quite prominent in both quality improvement as well as implementation research studies. Clearly, there just wasn't much information at all that implementation was being considered in this. John Weiss has made a very strong, articulated argument that that really needs to be considered almost from the start in terms of where you choose to run the trials and where you think about what's the next steps if you show that you can bring about them. It seems to me that there is considerable potential here for the use of what has become known in the implementation research field as hybrid designs, where you have both an effectiveness arm as well as an implementation aim. There's also some stirrings of thought in implementation research that in efficacy trials and effectiveness trials, there should be some, and what I would call anticipatory implementation measurement. So that if the randomized trials, and certainly in parenting programs because of a long history we have of good benefit being shown, if that's there, then you have the data to say, how do we move to the next step? To moving it into the field of dissemination and implementation, but having laid that groundwork earlier on. So the multi-site studies, of course, give wonderful examples of that. In almost none of these did I see any data tables that actually compared outcomes or processes by site, which is, of course, what you look for as you're moving further along in that way. So the next thing is what's in the pipeline. Joan's already looked at that in integrated care. We need now to look at what's in the pipeline for there's about 144 studies roughly that where we've crossed parent and primary care, 27 studies, et cetera. This gives you some notion of a plot that looks like projected new publications coming from ongoing or recently completed trials. So this shows that in 2010, we should expect from 50 to 65 publications in terms of what's in that pipeline. In other words, but our intent is to look at the trials, so we can see has there been any changes in parenting program studies funded by NIH that we can detect and we can project what will be coming out. Finally, here are some questions, it seems to me. The next steps of the review is to actually cross the work that we've been doing and see if we can find any studies that characterize implementation research, whether it goes from the choice of parenting program to bring in, which is a tricky issue, of course, for primary care because it's all done in different graded, in different age groups and that sort of thing. Hendricks, I think, is quite pessimistic. He says we're not going to find any studies about implementation. We'll see. But we have to cross it, and we'll see what's happening there. I think an issue that comes in quite a lot in these studies is, and some really go into the parental, obviously parenting practices, these randomized trials are changing parental behaviors, but that's about parenting children. The issue is, do they also get into behavioral health issues for the parents? Because those may indeed be, I mean, if you look at kids in foster care, they come from families where 40% of the mothers meet the criteria for clinical depression at a moderate level, functioning level. That's a huge behavioral problem, and we especially know that from Barbara, from the STAR-D trial, where if you really pushed well on depression treatment, you actually got a bounce effect on the kids themselves. Very promising sort of thing. Third, cost measurement and considerations for both pre and implementation studies. What about the payers? There's nothing in these studies that talks about cost, although certainly the abbreviations would suggest that they're trying to cut the costs down, both in time and possibly in money. And then what type of implementation studies seem feasible and what partnerships are needed. So I think with that, I'll leave it, and because I think we're going to move now to discussion. Thank you.